Okay, so Cardiocare is located in Abuja, Garki, Abuja, and essentially what we try and do is to place on hypertension. Just checking if my screen is showing well. Doesn't seem to be showing well. Now that we have that, we'll just continue. Okay, so for cardiovascular excellence, cardiovascular surgery, interventions that include stroke medicine, ICU care, cardiac intervention. We support entire northern Nigeria and entire Nigeria really in providing high-end cardiovascular services. From here, we believe that we can help in multiple ways, and so we are of healthcare workers, and that's why you are here. This webinar has 1.5 CMB points. So afterwards, see the webinar, you will also receive a copy of the slides, but I implore you to please take notes while we are. So this is a World Hypertension Day special. My name is here with me. I expect to have a great time. So this is essentially what we find it. Let us know how to stratify, how to properly treat hypertension, how to properly. We expect that we will define and diagnose hypertension properly. You will not be unsure. You will know how to properly measure blood pressure. A patient with hypertension. So if you come to your clinic, your hospital, you know what to do and what the treatment is appropriate per time. You will know what to do in special conditions and when there's a crisis, and you know when to refer. So we have this five-pronged approach, which is, well, let me leave that. So I'll leave. Okay. About the trend, about introducing hypertension generally, so that we can now proceed from there.
Okay, so when we talk about quantitative trait, that is highly variable. So in population studies, it has a normal distribution that is on office blood pressure, the global prevalence of hypertension.
That's a lot. That's almost 1 in 6 people globally. In Nigeria, it's about 23%, 23 to 28%. So done by Oga et al. In the East, where he went door by door knocking. He got as high as 30% people in the community. So you're about to talk about the awareness.
Yes, and from 29% to 60% we have, and globally, diseases are being treated. According to our 3.6% ODILI of Nigerians are on treatment. That's a very, very low number.
So it is very bad. Head of patients are treated in Nigeria. That's bad. That means that we'll continue to have this. That is why wizards and witches are plenty. That is why wizards and witches are more in the poor areas of the country. There, awareness is low. That is why the complications are low. People have heart attacks, sudden death in those areas. Globally, it's high. Control is only. The reason for this poor control ranges from the patient not taking the drug to the doctors not believing, to the doctors not knowing the proper things to do. But just to let us know that BP, everybody's face is different, everybody's hand is different. So it's a variable. It ranges from one area to the other. When we begin to worry about hypertension is when we say that this blood pressure, this person risk of developing a cardiovascular disease. That number, of course, is arbitrary. At what or a heart attack, we're not 100% sure. Different people may have higher cutoffs, and another people may have lower cutoffs. But suffice to say that people with lower blood without, and those are the things that is very pressures live longer. People with higher blood pressures live shorter lives, and so globally we have all come to it is the world's leading killer. It is above TB, even above malaria. And unfortunately, like ours, what happens is that people focus on leave this bad killer because it is not a direct killer. And so it is worrisome, both directly and in. You can see that it contributes a lot to the book. Can you talk about these hyperlogic factors? Meaning that factors that.
So this blood pressure in susceptible obesity.
Yeah.
The second thing is insulin resistance, high salt intake. We are talking about more than 5 grams per day. Most of us. Lipidemia, and then a diet that is low in potassium or calcium intake.
So a lot of people talk. There's no place in the world that is not stressful. Nigeria is not accepted. Nigeria is more stressful. I don't. That's the country. Anyways, all of these factors very implicated in people getting hypertension or having hypertension. We know hypertension is typically secondary to other diseases, and those that we call essential, and those that have essential hypertension. Did you ever know why they call it essential hypertension? Did you ever know why they call it essential?
It's a matter of course. It's to follow.
No, not really. Found in early 1900s or whatever. Yes. People with high blood pressure were taught that it was a normal. Get that high blood pressure to survive. So for them, it was called essential hypertension. Okay, so but over time, after studies, and they now found out that those people with that high blood pressure did not live as long. They had sudden death, they had heart attacks, strokes, they had that essential hypertension. I mean, hypertension now became an illness. That is why it remained as essential hypertension, but in reality, it is. That is how the name came about. I'm sure other people have different theories, but essential came about.
So, what are the cutoffs for the?
Okay. So in diagnostic hypertension, there are a number of things. A variable trait. It is something that an effort to try and give it a particular. We know that, of course, those with higher blood pressures have a risk action of heart failure, kidney disease, and of death. This correlation is more robust with systolic than diastolic. This is very important. A lot of people can say, no, it's only the lower one that is important. If you have 160/80, they'll say, don't worry. That systolic blood pressure even correlates more with this. So, over 80, that 160 is important. So don't wait for it. Quite important in the hypertension. Remember that the numbers we give are just to allow. For different people, there are different things, and there's no specific cutoff for anybody, and we cannot happen. So Hypertension definition is arbitrary, and the numbers we use are based. After we finish webinar, somebody comes out with a study and says people are lower blood pressure, that we will change definition. But for now, generally, first the blood pressure will measure in the hospital or the office blood pressure. Third, the blood pressure that we measure with ambulatory blood pressure monitor. So ambulatory blood pressure, Mr. Emmanuel, can you get ambulatory blood pressure from downstairs? And it's fixed from downstairs. So I'll explain about ambulatory. I will show you a device that we use. Ambulatory blood pressure is a device that we put on the patient 24 hours. It is measuring the blood pressure so that we can get the exact any of those three to be able to define hypertension. Back to your question, I'll more specific to your question. In the office, anybody that comes, and you can see we said either or both, so that you will not say that the blood pressure is 150 over. If you have greater than 140 and or, now the mean home blood pressure, the person will be checking their blood pressure at home, and then if we do this ambulatory blood pressure, I will show you the device. We have quite a number in Cardiocare for us to do for you, and we do the 24-hour mean. The 24-hour patient has high blood pressure, while the night time 127. First both ambulatory blood pressure about maybe 7 years ago, or no, what more than that. And I wanted to test the device. I called one of the working, so I put it on him to test how it is, free test. By the time he brought it back, his nighttime blood pressure. So I told him, "What are you dreaming of at night?" But at night, we expect the blood pressure to go down, no matter how the stress reach sleep. So then in the daytime, these are the typical cutoffs that we use right here in Nigeria and Abuja. So like I said, there are so many studies and so many different guidelines. So this is the guideline we want you to use for Nigeria. This is the guideline we want, combining everybody's own together. And this is what we think we should go with. We have these ones that try to select it into normal, and so on and so forth. But can you see something in this one? In the ACC or AHA one, we can see that stage 1 hypertension in their own definition, it starts from 130 over 8. Now this is quite important. Even based like the ESC, from 130/80, you need to start lifestyle therapies. So any person in your hospital, in your office, 130/80, assume they are hypertensive and start lifestyle therapy. Start the other things with. Not wait until they now develop 140/90, 150/90. So that is the reason why ACC and AHA had to bring this up. The lower you get the blood pressure, the less the likelihood of all the cardiovascular diseases. So I've asked them to bring something for us to look at. So can you tell us something? You are aware of the white? Before I talk about it, just say something about it based on what we're seeing on the slide.
Okay, so what elevated office blood pressure and maxed and normal home blood pressure. So a patient comes more less than 120/80, but here you're looking at them, it's 140/90. That's white coat hypertension. Now maxed hypertension is the opposite. So in the office, their blood pressure is normal. However, the recordings that they have 40/90. So that's
okay. So it's very important to know this. So if you have a patient with, now white coat hypertension is not innocuous. A lot of people used to say, it's just white coat hypertension, don't worry, don't need drug. No. A lot of studies have shown that there is still some correlation with negative outcomes with people that have white coat hypertension. So if the blood pressure is elevated in the office, you still need to go ahead with so many other things. Okay, you don't just assume. Now we know that blood pressure at home or outside of the hospital has better correlation with cardiovascular disease. So what they measure in their home, what to do with ambulatory blood pressure, relation with whether they will develop stroke, heart attack, heart failure, kidney failure, or whether they will die. Very, very important. So it's also important to measure. So when we are trying to assess somebody with blood pressure, it's like a tripod. The office blood pressure, the out of office blood pressure, and so home office blood pressure, out of office blood pressure, and cardiovascular. We use all three of them to be able to properly assess blood pressure. So if you look at this, for those that have been in business school, you will enjoy this chart because this is what we have all through. So in the hospital, this is the hospital now. In the hospital, if somebody has a normal blood pressure, you have to check what they have. Well, then we'll say it's fine. If, however, at home it is high, it's for 130 or 135 over 85. So if you are getting 136, 134 at home, and then you came to the hospital and you got 120, they don't have a controlled home blood. We call that much. Okay, so much is masked uncontrolled hypertension. And when they go home, it is abnormal. Those are the people that will say they are fine, but they still have the people that in the hospital is abnormal. Or it could be a sustained uncontrolled hypertension, such. Abi? For those now that are here, they will say, no, at home is 138. If you hear 138 at home, you will likely get 150. We always tell the patients, if you are getting 130 and greater than 180 at home, your blood pressure is not well controlled. Don't wait till 149. So in that case, the office pressure is abnormal, the home blood normal, and the out of office blood pressure is normal. That's what we call white coats. Even in white, the patient does not develop any cardiovascular side effects. So I think we'll just shoulder on. There is also the hypertension, exactly, which I've added, I'm saying RUCH. So it's resistant in that the person is having an abnormal blood pressure, but they are taking their drug properly. And one of those drugs includes a diuretic, and despite all of that, blood pressure. So, what do we do in such cases? I will talk about that a little bit, but just think need to be referred to a specialist. So they are taking up to 3 drugs, which include a diuretic, and they are taking it regularly. So we now call that a resistant hypertension. Thank you so much for joining us. We are reaching from Cardiocare. It's located in area 11. It's a specialty internal medicine and cardiovascular hospital. Advanced cardiovascular disease, including hypertension, heart attacks, strokes, cardiovascular disease, and we're able to do cardiac surgeries on emergency basis and routinely. We're able to put in stents, pacemakers, so that it does not result in any of the things we talked about. Okay, so in clinic now, what do you think? If somebody have 150/80, what will you do? Are they hypertensive?
Hypertension should be made after 2. But that value is our definition.
So that value on its own is definition. Everybody working in 150/90, you just say take this drug. That is what comes about this blood pressure is 150/90 or suspected. If that blood pressure is up to 160, no need for, and I mean 2 or 3, and I mean, okay, open the box. No need for go and come 1 week, because if you tell them to go and come, they might not come back. A, they could have a stroke or have an abnormal flow. 160/100, you do 2 or 3 times in the, and you still get above 160/100 and above. However, you don't. You do it in the office. I mean, the patient has 150/90. The patient has 150/90 or the like. What do? You go next to the next thing. What's the next thing? Consider repeating the office blood pressure. That is what you say a second time. Or do you, and if you get any of the value we talked about, or the patient can go home, and we also advocate is to do is a check for target organ damage. If you check and you find target organ damage, that is like left ventricular ECG is abnormal. Do you get it? One of those things I show you, you did fundoscopy, you saw retinal, then you are dealing with hypertension. Okay, but however, if that is not the negative, then in that case you consider white coat hypertension or other things, and then you still treat for maybe lifestyle. So 100 hypertension straight. Not, but you need to be sure. So this is what you do to be sure. Repeat the office blood pressure, ambulatory blood pressure. This is what the ambulatory blood pressure might be, if I can. So this is what the ambulatory blood pressure, very small machine, patient puts it, and then it is connected to this. What essentially it does, it checks the blood pressure every 15 to 30 minutes. It checks the blood pressure. It checks blood pressure every 15 to 30 minutes in the daytime. So that is essentially what it looks like. That's what it looks like. Like my computer seems to be angry. Just a minute, small break in transmission. Is that. If you have any questions, please put them in the Q&A box. If you have any questions, please put them in the Q&A for us to see, and then we'll answer once we get the opportunity. So if you have any questions, please put them in the Q&A. And then get your CME point, 1.5 CME points to your mail. You can rewatch this on our YouTube channel together with so many other, graciously by Cardiocare and her specialists, so that back to our approach. So the approach to Dr. ETC. I think that's a nice. Dr. Ngupe, don't you think?
Can remember it easily.
Yes, I for it. What did you? Maybe I'm just comment section. All right, so diagnosis, that will be screened. People that even come with malaria, people that come with whatever.
Educate, that will be the third one. The fourth, and then clinic follow-up, last but not least at all.
This is so diagnose, re-stratify, educate. Most Nigerian healthcare providers miss. I think number 2 and number 3. Just come hypertension, just start them on something. We can do better on. But it's also so the studies show that only 30%, less than 30%. That's because doctors, nurses, healthcare workers fail to treat to target because of fear, and some is because of knowledge. Okay, so talk about measure. How do we measure the blood pressure? No exercise, no emotional. That 30 minutes to 1 hour. Abby? Sorry, they are not hearing the audio very well. You can hear us very well. Very well now. I'm wondering if to do something about. Okay, so let's we'll hold on. Are hearing me well? Some people are not hearing from their. Just hold on 1 minute while we sort out the sound. Okay, how about now? I don't know if you can hear very well now. Can we hear very well? Good. Somebody is saying I can hear loud and clear. It's better now. Okay, fine. So that's what we use. So, Dr. Ngupe, you were talking about the preconditions for blood pressure. What you need to do, right? Go ahead.
Said no exercise, no emotional excitement, no caffeine in the last 30 to 60 minutes. And then the position of the patient is very important. They should be in a resting and supported position. Their legs should not be hanging off of a bed or off of a chair. No crossed legs. Their arms should also be supported. And
Okay. So, and then of course, no clothing. So somebody comes to your clinic and they are wearing a suit like this, you have to remove it. I mean, you just have to remove it. There's nothing you can do about it. Okay, I know sometimes we are worried about the dignity of the people and other things, but you have to do what you have to do. So make sure they are properly, that there's no clothing under the cuff. Remember that blood pressure can change by as much as 50 millimeters of mercury. So if you don't get it right, you might be giving the person a blood pressure that they don't have. So that is very important for us to know. Okay, thank you very much. I can hear that everybody says the sound is much better now. Thank you for the feedback. Okay. So what are the other things? It should be in a quiet room. They should not be browsing on their phone while they are checking their blood pressure. They should not be talking to them or talking to other people. And nobody should be talking to them. Okay. And then what else? Digital preference. Do you know what digital preference is? Sometimes some people check blood pressure and they always get 120/80, 130/80, 140/80. That's because they are rounding up or rounding down. That is very, very risky. A patient may have 130 or 140/92 or 94. That is uncontrolled blood pressure. But because of rounding up or rounding down, called digital preference, you will round it down and you will not adjust the treatment accordingly. So that is very important for us to know. So that's very important for us to know. Just a minute, I want to make sure I'm hearing some echoes. All right, so no digital preference. So when you want to measure blood pressure, there are three major ways: the mercury sphic, the normal automatic sphic, and aneroid. No, some people prefer the mercury. Mercury poisons the environment, so it's being phased out in most developed countries. Most of the electronic devices are okay. Okay, but there's a difference between the professional one and the home one. To give you context, professional digital blood pressure monitors sometimes cost as much as 700,000 for just a blood pressure monitor, while the one that patients have at home costs 30 or 40,000 naira. So if you are in your clinic, don't go and use that one for home use that uses batteries or something. You should have the professional one, which so that you can get a more proper and validated one. And then that aneroid, you remember that aneroid, the aneroid one. Okay, so you can continue about how to measure blood pressure.
Okay, so these are the devices, and then 2 or 3 measurements should be taken at each visit and averaged, and at least 1 to 2 minutes should be allowed in between the measurements. And then BP values obtained outside the clinical setting are lower. We mentioned that. However, they correlate better with end organ damage compared to the measurements that we get in the office.
It's also important to note that if you are in a hospital like Cardiocare or any hospital, like even where I trained, the government hospital, blood pressure at nursing stations is typically lower than blood pressure in doctor's office. That is, so don't be saying maybe there's something wrong with your feet. No. So blood pressure at home is lower. Blood pressure with the nurses, no nurses are friendly, nicer. Oh, nurses is lower, and then blood pressure inside the doctor's office is higher. So that typically is what we see. Now, remember that when you are checking that blood pressure and you have taken it, you have done once or twice, if you don't rest in between, so that's the reason why you have to make 1 to 2 minutes. After a while, the pressure in the hand from occluding that flow will rise, and that will give you a pressure that you might be wrong. So very important to leave that 1 to 2, 3 minutes in between measurements, and then take an average. That will give you a very one. These nice ones that look on the wrist, very nice. People don't have to undress, that to do. They are not recommended. They can just give an idea of blood pressure, but really they are not the recommended. They're not the recommended one. I know all of us like it. It's simpler, it's nicer, but they're not recommended. Some people even have watches that they say are measuring their blood pressure. They are not recommended. You cannot use them for treatment or for anything. Maybe you can use them for monitoring. I don't know. Maybe sometimes they can indicate, but once they indicate, you need to go to a proper sphic to have a proper blood pressure monitor. Okay, I'll take some time and explain this. This is very, very important to me and to all of us here. Now, I want you to just look at it very well and to be sure. First is that the sphic should take up like only about 2/3 of the arm. It should not be too small, like you can see on the right side of the screen. It should be, you can see the cuff width. It should cover the arm sufficiently. Because what it's going to do is that it's going to reduce, occlude the blood flow in that region. And then slowly, as the blood pressure is coming, as the blood flow is coming back, that is how it measures the blood pressure. So if you have something that is coming out a small area, you will need a higher pressure to occlude that blood flow, and that will give you a wrongly high blood pressure, and you could be treating somebody unnecessarily. And if you have one that is too big, it could give you a wrongly lower blood pressure because it could occlude it too fast, and then it will look as if you don't need a high pressure to occlude it. So you need one that is just right. So in most clinics like ours, and you should have multiple sizes in your clinic and in your wards for different sizes of people. You cannot, I repeat, you cannot manage people with blood pressure with only one size of cuff in your hospital or your clinic. You must get the appropriate size. Now, off to the next picture that you are seeing in this series. First is this thing we call an index line. Some of you have not seen it before, but right now, when you leave this webinar, you will notice it. So on the measuring thing, as you can see, I'm showing you, there's the white line here called the index line. So we can see it is at the edge of it. Some of them are labeled like this one is labeled index line. Now that index line, by the time you fold it around the patient's hand, it should land in between this range finder so that you are sure that that blood pressure is, blood pressure, that cuff is the correct size. So besides the height of the cuff, is that it lands in between. So if you look at my video, you can see this one that I'm taking round and round and round. And now look at the range finder in the video, and you can see that it now lands, it should land in between from the range finder. If it lands outside, it's either too big or too small, and that will give you changes in blood pressure up to 20 meters of mercury. Can you imagine somebody you told the person has 160 or 180, and you started rushing to give hydralazine or something else? Or you told somebody he had normal blood pressure, meanwhile the blood pressure, you told him he had 130, meanwhile blood pressure is 150. Okay, so this is very critical for us to note. Dr. Kupe, do you have anything to add about this? Okay, so let me try and remove all of these drawings. Okay, fine. All right, so additionally, what we talk about the fingers? Yes. Additionally, point 3. What do you think, Dr. Ndube?
At least the cuff shouldn't it shouldn't be too tight around the patient's arm. At least 1 or 2 fingers should be able to go in.
So sometimes people try to tighten it, tight it like it's a wrapper, like let it not fall down. No, when you put it, you should be able to have that, 1 or 2 fingers that can enter under it, so that you now have it. Now, number 3 thing is that you should make sure that what they call that thing? Like this air tubing aligns well with the artery. Remember, the artery is on the medial part, the inner part of the arm. So you want the artery. So you need to go back and teach all your nurses. I think we have over 200 people now logged in for this. Welcome. This is a webinar by Cardiocare. We're teaching on hypertension. And we are now talking about how to measure blood pressure correctly. I'm sure you will go back and find out whether you're doing it correctly or not. So make sure that it is somewhere in the middle of this bladder. If you look at this, any fig cuff, there's a part that inflates, just about half of that, like a ball, no bladder in football. So that half that is your artery should lie in the center of that bladder. The reason is that so that it is even pressure that occludes that artery and it gives the correct pressure. If it lies to one side, you will need a higher pressure before it will occlude that vessel, and therefore to give you a higher systolic, or vice versa. So, but if it lies in the center, then it gives you the accurate one. Have you considered all of this before? Very important, right? Very important. Good. I will just talk about mercury's fig. Some people that do not mercury's fig, I'm not sure we have much mercury's fig again here. Do you have any mercury's fig? We have a few, Abby. Let me get a mercury's fig so that I can explain something about mercury's fig since we have people from all over the country on to explain. The first thing about mercury's fig is that after you have put the cuff, do not just take your stethoscope straight and start listening. You will likely miss it. Very important. Do not take that again. So when you put the cuff around the arm, first of all, palpate the radial pulse and then inflate until you stop feeling the radial pulse. Then deflate and mark in your mind where the pulse started appearing from. That should give you a rough idea of the systolic pressure. And I'll tell you why that is important. If not, if you don't do that, so when you start listening, the first sound you hear, the cough sound, will start, and then it will go silent. Right? That's how it happens. Then another set of sound will start, boom, 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 boom. So let's assume the first sound started at 190. It goes silent, starts again at 150 before it goes away by maybe 100 or so. So you will now say, so if you did not do that palpation first, you may mistake and start hearing from 150 because you occluded when you reach 180, you now started the head at 150, you now say the blood pressure is 150 over 80. Meanwhile, the real blood pressure was 190 over 100. So it's very important to palpate before you start occluding. So you palpate, do it, let the thing come down, then you now listen. The point where you hear the first sound is the point, and then the point where the sound disappears. And then don't round up. Don't just go from 132 and say it's 130 or go to and things like that. So I think those are the key pointers for mercury. I don't use mercury much anymore. So, but those that like it, whatever the case, make sure you can do both of them properly. Okay. So, talk about recertification. Please go ahead.
So how is hypertension investigated for risk stratification? First, we should find and alleviate target organ damage.
Yeah.
So if patient presents to you, investigations are very important, and your examination, of course. And then secondly, we go to the risk stratification. Identify other cardiovascular risk factors that the patient might have, exclude secondary hypertension, and any compelling indications for certain drug therapy.
So it's very important that you risk stratify. Most times we just start treatment without stratifying the risk. What is risk stratification? We'll talk about that shortly. But very important that risk stratify. I have a mercury fig here for all of us to see. Now it is the mercury fig particularly that you have to put the fig at the level of the heart, particularly because it is measuring it with atmospheric pressure against this. So it's the mercury, but in the other ones, you may not necessarily have to put it. Okay, but I don't have a study to back that. So typically across the heart, at the level of the heart, and then all those things we talked about. This is the typical one. Also, in the mercury fig, just like I talked about, there's a bladder. In this case, you can see some of them, the bladder is very small. So if you know it, you can see bladder, in this case, it's just very short from here to here. You are now putting it at the end of it. Most of the mercury fig may not have the index marker, but they almost always have the range finder. So go to your mercury fig now, you will see the range finder. You will know that the arm that can enter this is only from here to here. Anybody that use bigger, you're likely just doing your own blood pressure, doing a wrong blood pressure. Okay, so how do we investigate? Typically, I would say that there are two types of investigations. What I call first line, that is for everybody, and what I call second line for some. Everybody that comes with hypertension, ideally, if money is not a problem, should have urinalysis, electrolytes, urea, creatinine, uric acid, should have fasting blood sugar and or HbA1c, should have cholesterol done, should have PCV, should have ECG, should have echo and chest X-ray. I know some people say, okay, maybe we don't need it. But you've seen here that sometimes somebody got blood pressure and then we see the pick heart failure, we pick severe reduced ejection fraction, we pick things that, pick serious valve abnormality. So it's like road safety. When road safety catch you for one, they check for all. So if you find hypertension, the other things may be there. If somebody not wearing seatbelt, chances are you don't have trial. So that's how road safety goes. So for all of us, I don't think we are road safety. Those from road safety, I'm your friend. Please don't catch me. And then of course the second line ones. So which are the second line ones now? Go ahead.
The renal artery Doppler abdominal pelvic ultrasound scan, renin levels, 24-hour ambulatory blood pressure, which we spoke about, gyroscopy, and cortisol screening in some patients.
Okay. So this second line is not for everybody. There are people that need it. There are people that it's indicated for. So for those ones, you need to do them. But this first line, as much as possible, do it for everybody. I know that some people may not be able to afford it, but at least do what they can afford. And then you will see why it's very important to risk screen. For ambulatory blood pressure, which I showed you the device just a few minutes ago, there are two reasons for doing it. The first is for diagnosis. All people that come with 150, 80, 140, 90, you've kept on two occasions, it's 140, 85, you are not sure. Borderline. Those that, or even high number, they come 130, 85. Those that have suspected white coats, those that you are thinking that maybe they have hypertension at home, especially if you find out that they have target organ damage, like ventricular hypertrophy, like they have MIs, that they have protein in urine, and their blood pressure is normal. Doctor, my blood pressure is normal. Those people you need to put ambulatory blood pressure to be able to find out maybe they have blood pressure that are high around other clocks, around other times. And then for control, anybody with very high risk hypertension, anybody with advanced target organ damage, drug resistant hypertension, we need to now be sure about the control and whether they have good 24-hour control. So, for example, somebody has had a stroke, they are on drug therapy. It is very important to do ambulatory blood pressure. Okay, if you cannot do it in your center, you can just refer them here. We'll do it for you and then give you the feedback. So that you can be sure that you have 24-hour blood pressure control, not that particular times of the day their blood pressures are going to 170, 100, and they've had a stroke before. That is very, very critical. For anybody that has seen a patient that had a stroke, it is very devastating to the family. So they cannot have another one. It's too costly for them. Okay. So go ahead.
Now,
So
these are some of the risk factors
yeah.
we're talking about. For the gender, males greater than 55 years of age.
Why only men?
Well, actually, in women as well. So it depends. The gender, age also plays a role. At
Yeah.
some age groups, it's lower,
Yeah.
and so on and so forth. And then smoking, family history of premature cardiovascular disease, obesity, total cholesterol level greater than 200 milligram per DL, or increased elevated LDL levels or low HDL levels, and then elevated uric acid levels, patients who had diabetes, and previous established cardiovascular disease.
So everybody that causes hypertension, you must check for these risk factors. If they have hypertension in addition to these risk factors, these are additional risks that you should take note of. These are additional risks. So what are these established ones? So stroke, TIA, they say they could not move their hands suddenly, but after a while they could move their hands. Those are established. It means that they're already having problems. Heart failure, people with kidney failure, they have protein in their urine, they have intermittent coagulation, peripheral arterial disease, they already have established risk. Or if they have HMOD, hypertension mediated organ damage. All these things are what we do. So let me start again. First, we do the risk factors. You check for any hypertension mediated organ damage. That is like LVH on ECG or echo. Sometimes even chest X-ray may help to show that the heart is big. Proteinuria, microalbuminuria, creatinine is deranged, atherosclerosis plaque, or fundoscopy. Fundoscopy is critical. You look at the eyes in people with hypertension and you straighten hemorrhages, they have already started having organ damage. Even if their blood pressure is low, you need to treat. So it's normal, you need to treat, sorry. And then those that have had established ones. So any of these things will help you in your risk stratification. So now let's go to risk assessments. If the person has low or normal blood pressure, it looks as if the blood pressure is high normal, 130, they have 135, 85. They enter your clinic and you are saying, no, I should not do anything about it. If they have no other risk factors, it's low risk, you may not treat, you may do other things. But however, if they have HMOD, CKD, or diabetes, that is moderate to high risk. So you can see why the risk assessment is very important. So some people are in your clinic right now that are high risk or very high risk. They've had a stroke before, but they say, doctor, my blood pressure is now 130/85. No, that is very high risk, and you need to be more aggressive about the treatment. So very important. In the disease staging of hypertension, we say stage 1, hypertension, uncomplicated in this risk assessment way. Stage 2, they have something that is happening to them, but it's not symptomatic. This is why, as Cardiocare, we advocate that everybody with hypertension should have an echo at least once. Okay, so you might find left ventricular hypertrophy, you might find ejection fraction is very low, but the person is not yet in heart failure. But ejection fraction is 30%. Okay, then stage 3, they now already start having symptoms. Everybody that has established disease with symptoms is very high risk. Their risk of death is very high. You cannot play with them. And then those that have asymptomatic disease are from moderate to very high risk, depending on how high their blood pressure is. And those that have no of the issues, just some risk factors, one or two risk factors, they are the ones that range between low and high risk. So very important. This picture must be in your mind anytime a patient walks into your office with hypertension. This picture must be in your mind because people die unnecessarily. So somebody comes to my office now. He's had an MI before, a heart attack before, or he had peripheral vascular disease complication, and his blood pressure is 145/90/80. What kind of risk is that?
Very high risk.
Very high. So for that person, 145/80 is very high. You need to check his cholesterol. You need to start intensive therapy. You need to bring down that blood pressure. That same person, another person comes in next person that came in, same blood pressure, but does not smoke, does not have diabetes, has never had any risk factor. What would that be?
That would be no risk at all.
That would be low risk. Low risk. So in that case now, if that's the kind of person you might even say do lifestyle first, go and exercise, reduce salt. Same blood pressure reading, two different people, two very different approaches. This is why risk assessment is key. If there's nothing else you get from this, get this one. I can see that we have over 200 people. Please we are appealing, get this. We don't want to see patients when they already have heart attack. Yes, we are able to treat them with our cath lab, put in stents, put pacemakers, but we think we can do much more in Nigeria. That is why we are having this webinar to educate you. So this picture should be on your wall. It should be on your office table. You will get the slides after now so that you can go over it again. So remember, Dr. ETC, we've diagnosed properly, we've done the risk assessment. So next thing is education. Is education. So what is the most important component and bedrock of hypertension treatment in Nigeria? Yes, can we put in our chat box what we think is the most important component before we go ahead to the rest of the treatment? Anybody? Can we put in the chat box what we think is the most important component and the bedrock of hypertension treatment? Yes, I'm looking at the chat box. Okay. Yes, people say lifestyle, some people say diet, lifestyle, somebody say education, somebody say counseling. Okay, dietary salts. That is the most important. Drugs, yeah? Very, 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 very important. Drugs. Okay, fine. I can see so many Adams Edwards, welcome. Okay, diet and modification. Fine. As we can see, the most important is education, education, education. It is the bedrock. Lifestyle depends on education. Taking drugs depends on education. If you're not educated properly, not just the patient, who else? The doctor. That's why we are here. The doctor. Sometimes the doctor says your blood pressure is fine. Now you can stop your drugs. Please, please. So we'll try and move a little bit faster. Try and move a little bit faster. I hope we can finish all we have to say about hypertension treatment. Okay, so the bedrock is education. What are the key things they're educating about?
So the disease nature.
Exactly.
What is hypertension?
Yes, every patient should know about it. Go ahead.
And then cardiovascular disease, educating them about their risk profile, what we have found in them and why they need to be serious. Investigation findings, and then hypertension-mediated associated organ damage. This is also associated with investigation findings. We're educating them about their diet, about salt intake, why it's important, and to what value they should take, and then lifestyle modifications. And then if the patients are taking other medications, for example, NSAIDs, an example, diclofenac, herbs, herbal medicine, targets, that's what they have and what value we are planning to get to. And then expectations. This is very important because the patient and the doctor need to come to an agreement.
Yeah.
And then red flags, what they need to look out for, what we've seen, and they need to pay more attention to. And then adherence.
Their drugs.
Their drugs and follow-up.
So I'll add one more thing. What will I add? It's there, but I'll just emphasize it. Every patient that comes to your hospital, warn them about market doctors, about friends and family, who will tell them to stop their drug, who will tell them to take urine in the morning, who will tell them to bath with your bleach, all kinds of things. Tell them ahead of time so that they will not be hearing it. Oh, they told me to stop my drugs and take Zobo, to take Celgivity, to take Celgivity. Let me not say more than that because we are online, Abi. To take one bitters or the other, that their blood pressure will go. Let me not say what is in my mind. But all of the healthcare workers that have told me to do that, and the people came back with a stroke, their blood is on you. So very important follow-up, and this is a very passionate topic for us. So the lifestyle essentially is reduce salts, reduce weight, eat right, alcohol, reduce alcohol and smoking, stop smoking. If you can stop alcohol, exercise regularly. Now, very important to mention that when we talk about exercise, they should not start exercise while their blood pressure is uncontrolled. So exercise is for people whose blood pressure is controlled. Their blood pressure should not be 170, 100, and they are doing exercise. So the blood pressure should be well controlled. And then, of course, once they're well controlled, they can now go on a regular exercise. I'm talking more about aerobic exercise. In terms of diet, it's lose low in saturated fats, reducing salt intake, and being physically active. Stand up. Even those that are listening to us, stand up. You cannot stand up, like if not, you will not see us. Otherwise, stand up. There are some things here to also note. Aerobic exercise typically say 90 to 150 minutes per week, with some resistance training. Weight loss, we typically will see about 10% of the body weight. But look at the effect on the blood pressure. It reduces blood pressure by -5 in people that have hypertension and -2 in those that don't have hypertension. If people eat right with vegetables, with fruits, in those that have hypertension, they can reduce their blood pressure by as much as 11 millimeters of mercury. So you can see that is almost equal to starting another drug. And those that have normal blood pressure reduces by 3, and then reducing sodium, resistance training, reducing alcohol. It is very, very important to reduce this, and you can see the impact it has on the blood pressure. I'm having to move a little bit faster so that we can finish on time. So about treatment, how do you start treatment?
So we already spoke about the risk stratification.
Exactly. So the risk stratification is critical in everything we are going to decide. Okay, fine.
And based on that, once someone has low risk, lifestyle treatment is there. Lifestyle, low risk, moderate risk,
Everybody.
very high risk. Everybody should be watching their salt intake. They should be sleeping. They should reduce alcohol. They should reduce smoking. Now, when do we consider drug therapy? Once we are approaching the low to the moderate risk. And then we spoke about other risk factors. What are their cholesterol levels, for example? If the LDL is less than 190 and someone who is already low risk or low to moderate risk, lifestyle therapy, less than 160, we should consider starting drugs. If someone has moderate risk,
sorry, I mean greater than. It's meant to be greater than. Sorry.
yes,
Greater than. Sorry about that. That will correct that in the slide you receive. So if the LDL is greater than 190 in low risk starts, if it's greater than 160 start, if it's greater than 130 in moderate risk start, if it's greater than 90 starts, if it's greater than 50, anybody with very high risk, you must start. In fact, some people advocate that everybody with very high risk, irrespective of what it is, starts. Okay, and then we target this blood pressure. However, there's a caveat. If there is end organ damage, of course, there already be on moderate risk, you should start drug therapy. If you think they are low risk, but you are not sure about certain things, especially end organ damage, you should consider starting. It is a very simple way of deciding whether you are starting or not. Okay. Then we'll talk about these compelling drugs. If the person has left ventricular hypertrophy, this is the drug to use. If they have heart failure, this is the drug to use. So you can see the different drugs. It's only in pregnancy that we consider Aldomet. So if you are using Aldomet, Brinedine, those other kind of funny drugs I see, there's really very little place for it in modern treatment of hypertension, because it is not about reducing the blood pressure alone. It's about reducing the risk. It's about treating the risk for the cardiovascular disease. So this will not guide you. If somebody has diabetes, you want to use more of ACE inhibitors, ARBs. If somebody has a nephropathy, these are the drugs. Once you can see that ACE inhibitors and ARBs are there in most of them, so you are very unlikely to be wrong and in choosing them for any of them. There are several reasons. They've also had much more studies because there's a lot of pharmaceutical industry backing in that. Okay, but we also know from the science. So everybody has lifestyle changes, and then drug treatment. Once greater than 160 over 100, start drug immediately. Don't say go and come back. Start drug immediately, and we typically try and get complete blood pressure control within 3 months. You don't want to start drugs. Somebody is 170, 100, and you want that by the time he comes next time, his blood pressure is 120 or 110, 80. No, that is in 1 week's time, in 5 days' time. That may be too fast. And there are several reasons for this. Because the different arterioles have started adapting to that high blood pressure. If you bring it down too fast, it could cause some problems. So you want to do it in a graded approach. And this is from the European Society of Cardiology. Okay, now, if patients have asthma, avoid beta blockers. If their heart rate is low, avoid beta blockers. If they have any high-grade block, avoid some calcium channel blockers. If they are pregnant or even trying to get pregnant, consider avoiding pregnancy, ACE inhibitors. Okay? If they have kidney renal artery stenosis, you should also avoid ACE inhibitors. Okay, so very, very, very important in what you should not. So this slide is what you should not use. If patient have gout, you should not use thiazides, and the like. It is not the very best. Okay, so about escalating drugs, Abi? What? Yes.
How do we start?
How do we start? How do we increase, Abi? Everybody's always confused about this. What do we do next? Patient has been on drug. Now they come to you while on drug, they are 150, 100. Important thing is start low dose. combine, and then increase the dose. That's the baseline of it. So you have these compelling indications for the compelling indications that we put behind for different ones. Start low dose, combine while you're on low dose. So you want to give two low doses so that you reduce side effects and then increase the drugs. So you don't want to give the highest dose of one drug sometimes. You want to give second drug before you now go to the higher drug. That is the underlying principle. So generally, we start with, let me move faster. Generally, we start with either an ACE inhibitor, a calcium channel blocker, or a diuretic. We only consider beta blockers if the patient has ischemic heart disease, heart failure, or things like that, then we cannot add that in. But plain hypertension, typically A, C, or D. But it can be A, B, C, or D. And especially those people that have blood pressure less than 160/100, you might start with one drug. Low dose, if it's not controlled, combine, then increase to target. So if they have two, if they are step 2, blood pressure 160/100, start with 2 drugs. Either ACE plus calcium channel, or ACE or ARB plus diuretic, or especially patient with heart failure. That's why it's faded out. A and B, you might consider that for people with heart failure. A or ARB plus beta blockers. They have heart failure, if they have palpitations, if they have arrhythmias, if they have possibility of an aortic aneurysm, you want to combine in that way. So it's still not well controlled. We'll now add a third one. So if you were doing A and D before you add C, if you were doing A and C before you add, and so on, vice versa, you add. Now it's still not well controlled. By this time that we're talking of resistant hypertension, in which case you add X. Further diuretics, especially mineralocorticoid and thyroid, that's spironolactone. Spironolactone dose in hypertension is not 25. 25 is the dose for heart failure, while for hypertension, the dose is 50 milligrams. So you might now add, or you give further diuretics, or it is at this point now you can bring alpha blockers, doxazosin, aldomet, and all of the like. It is only after you have done this one, because those alpha blockers don't typically have much benefits, cardiovascular benefits, like we've talked about in terms of risk management. So, yes.
So, still on the escalation of drugs, what is the core drug treatment strategy for uncomplicated hypertension? We spoke about using either one pill, that's the initial therapy, or starting with dual therapy. And then in the box there it says consider monotherapy in low risk grade 1 hypertension, that's BP less than 150 millimeters of mercury, or in patients who are much older or frailer patients. And then step 2 is when you're using an ACI or ARB plus the calcium channel blocker, and we're adding the diuretic.
We're going up.
Yes, sir. And then the step 3 is adding the resistant hypertension, adding corticoid
Antagonist
or doxazosin.
Do we use aspirin? Zebediah has sports cost wahala. Remember, you didn't watch Zebediah adverts. No, you didn't watch it. I mean, am I that old? I'm not that old. Zebediah adverts where Zebediah say Vasoprene. So. Because of that, the whole country takes Vasoprene as antihypertensive. Even doctors believe the same thing. No, aspirin is not for everybody. In fact, some patients wrongly think that the antihypertensive, aspirin hypertensive. Do not give aspirin for anybody that the blood pressure is uncontrolled, because rather than prevent, to not increase for hemorrhagic stroke. So blood pressure must be well controlled for those with aspirin. So prescribe other drugs. So it is typically those that have a 10-year cardiovascular risk, who 10-year cardiovascular risk greater than 20%. So everybody who is watching us should go and download MD-Calc, MedCalc, or in fact just go on Google and look for the ASCVD calculator. You use that and calculate the 10-year risk. That is, what is the chance that this person will develop a cardiovascular disease within 10 years. If it's up to 20% and BP is controlled less than 150/90 and there's no contraindication, you may consider aspirin. So aspirin is not for everybody, it's for only those who are age greater than 50 and whose 10-year cardiovascular risk greater than 20%. Those are the people that will take aspirin. And for those with statin, those are not on target. Remember, I showed you the target before. Or if they are same cardiovascular greater than 20%, 10-year risk greater than 20%. So follow up. So Dr. Ngupe, how do we follow up?
Typically, it should be when you diagnose the patient, once BP is not yet controlled, you want to see them at most every month, at most. Yeah, so 1 to 4 weekly follow-up till the target is reached. However, if the target has been reached, we can increase that. It's very important that during follow-up, the patients have been counseled on keeping a home BP chart. Every follow-up, we need to see what's going on at home. And then number 3, we need the yearly organ function survey. That's checking for is there
proteinuria,
exactly,
left ventricular hypertrophy, and all of, and if the creatinine is going too high, all of that will be checked.
Yes. And then the fourth factor there is low CV risk. That's when that's still back to checking the risks for every patient that you see. We are checking. So at an initial visit, your patient might take your advice and do lifestyle therapy. So their risk could actually improve. So we should reassess that at every visit. And then the intervals is also very important.
Very important that the follow-up is for life. Tell your patients the follow-up is for life. People want one thing that will solve all. It is not true. It is not possible. The follow-up is for life. The risk in somebody's life changes over time. So someone will say, they gave me drug. I've not got hospital for the past 3 years. I've just been taking my drug. Very well, my blood pressure is controlled. No. If they don't come in, they may not pick those risks when they are started changing. Now, those that have low risk can be followed up in primary care settings. Once they begin to have high or very high risk, they should be followed up in a specialist center. So you can refer to Cardiocare or any specialist center that is close to you. Okay, so make sure they are followed up in a specialist center if they are very high risk or high risk. Now, moderate risk can be followed up with a doctor. Okay, should be followed by a doctor, while low risk can be followed up in a primary care setting. It's very important for us to encourage our patients. When Abuja, I know, so a lot of patients can get their own feed. But in most places, people can get their blood pressure checked for 50 naira or something for the people that walk around the market. They can check their blood pressure in the pharmacies. So we typically want them to do that kind of, get some home blood pressure monitoring and keep a chart. Because remember the tripod, risk, office blood pressure, and home blood pressure, what you are using to assess the patients when they come for your follow. So when they come for the follow, what do? Re-educate. Remember, education is very important. If they leave your office, they have heard so many other things. So right now, you need to give your own back. Otherwise, they will forget what you said before. Re-educate. This is the most important reason for follow-up. Review whether they are following your drugs, whether they have any side effects. Like erectile dysfunction is the common side effect, and patients will stop drugs at the risk of having a stroke. So you have to ask them specifically. If they tell you they're having, you may need to change their drugs to get better drugs so that you can find any problem. Then you need to check for any complications. Are they having edema? Are they having chest pain? You need to ask specific questions. A lot of people may not tell you, even though that they have all of these things. They may not tell you. So you need to ask specifically. So check and ask specifically for them. Then review other risks, diabetes. A lot of times patients develop diabetes during the course of treatment, or either because of drugs sometimes, but more often than not, people that were going to have diabetes, since you were following them from 30, they are now 45, and they have now developed diabetes. You have to be checking it. Uric acid, all of these things are risk and will cause them to move on that our risk scale. Okay, and check for their protein, and then, like we said, do your ECG at least once a year. Do a full checkup once a year. You may do it more often if there's a problem. So, for example, if you have proteinuria, you may do it every 3 months. If you have an elevated cholesterol, you may do 3 to 6 monthly to make sure that you are getting target, and then you adjust medications. Do not accept 150/90. It's not target. 150/80 is not target. 140. In fact, even sometimes in patients that have heart failure, 135/85 is not target. Adjust your drugs. So most of the reasons why people are not well controlled is because of doctor inertia. Doctor sees 130/85 and says, maybe he did not sleep well. Don't worry, come back later. No, you have seen it and the person is not at target, and you need to. I remember a case, one of my colleagues many years ago, patient came with a stroke, and I was like, he has been on his drug. Only for us to check the file and to find out that many years ago, to find out that his last visit was 2 weeks earlier, his blood pressure was 150/90. And the person said, no need to adjust, just take your drugs well there, stop taking salt. Only for the guy to come down with a stroke 2 weeks later. That patient was so bitter. Okay, so those are some of the things. Make sure they have come to see you. They must get the best. It is a marker of quality of care if the patients you are managing are coming down with heart failure, with stroke. Meanwhile, they were coming to your clinic regularly. What's the point? What differentiates them from those that did not come at all? So we need to do that for them. And then these are the targets. We want to keep their BMI low. Sometimes it's not possible, so you need to advise them. And I think you can watch our webinar on YouTube on weight loss. Is there on weight loss management, medical weight loss management. You can check on our webpage, cardiocare.ng. You'll find the link to the webinar. For blood pressure, we want the blood pressure target to be 125/75 if they have diabetes and they have proteinuria. 130/80 for everybody that is high risk and very high risk. I will not accept 135/85, except they have symptoms of hypertension. So some people, once blood pressure goes to 130, 120/85, they start feeling dizzy. Then you are going to low. So if patient is symptomatic, please don't do that. So apart from that, you are targeting less than 130/80 if there's heart disease, anything. And if there is no risk factor, low risk, you are targeting 140/90. In the elderly, and they are low risk, you may target 150/90. People above 65, low risk, no issues, you target 150/90. Pulse 60 to 90 normally, but those with heart failure or ischemic heart disease, 60 to 70, and check for their dorsalis pedis, the pulse with their legs, and check that their pulse is regular. Sometimes imagine a patient, the pulse has become irregular. You need to check. So don't just drug refill is an aberration. It should not happen in a hospital. It can happen in a pharmacy store, but it should not happen in a hospital. I know there is insurance office pressure and so I say drug refill, but it is not correct. Drug refill should not happen in a hospital. A patient comes, they should be examined, their pulse should be checked, their blood pressure should be checked, their heart sound should be checked. Are new irregularities forming? Did they get proteinuria? Has LVH come across? So those are the things that we are now checking. And then urine and check their general, whether they have developed edema, so once you see those things, this is a red flag that you are having HMOT, health, not HMO disease, health, hypertension mediated organ dysfunction. We are running out of time. So this last slide, I'll take them a little bit fast. Please bear with us. I could just answer questions. I will just run through them. Dr. Gupi, I think we can just do that. So for crisis, any acute elevation of blood pressure greater than 180, 110 is hypertensive crisis. Either they do not know. We'll now define the hypertensive crisis into whether there is ongoing organ damage or there is none. If there is no ongoing organ damage, we call it urgency. And if there's ongoing organ damage, we call it emergency. Very, very important. It's very important to differentiate because in urgency, you will just adjust their oral drugs and watch them over days to weeks. While in an emergency, you need to admit them to the ICU, refer them to a specialist, and try and bring down that blood pressure over hours to days. So you want to bring it down slowly over hours to days, while in urgency, you want to do it over days to weeks, since there is no ongoing organ damage. So it's very important for you to differentiate, but urgency is more common. Please, never, ever, 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 how many times have I said that? Not enough. Never, ever, ever give sublingual nifedipine. Never, 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 ever. I can see 212 people on the chat. Please take our message, form a song. Never, ever give sublingual nifedipine. You will kill that patient. You will give sublingual nifedipine and you'll be the one to cause the stroke. Okay, so it is erratic and it crashes blood pressure too fast and it is being absorbed in very rapid ways. Please never ever keep this in your mind. If not anything, at least let this one. I'll be happy small. Instantly crashing blood pressure that was very high is almost always a bad idea. Oh, we get referral. Somebody was blood pressure was 250 over 130, and we have brought it down successfully to 120/80. When the patient comes, they'll be unconscious. It is you're bringing down that even cause more harm than good. Please. The body will try and get used to that high blood pressure. So you need to bring it down slowly enough for the body to adapt in a controlled setting. Okay, so I'll just move fast. Just let you know that in a hypertensive emergency, you should admit to the ICU, you should have IV treatment, you should ideally have interarterial blood pressure. Somebody say, what are nifedipine drops? Nifedipine drops can never be used. It is the same thing as this one. Never, ever, ever, ever give nifedipine drops or sublingual nifedipine or any of those kind of things. Please give your oral drug if you don't have. Give your oral drug if you don't have. Okay, so let's go back. So for emergency, blood pressure is very high. Our goal is to reduce by MAP by 25% only. we want the diastolic blood pressure to remain above 100. So somebody came into your hospital 210 over 130. That diastolic should remain above 100. Don't bring it down to 90. You will cause a stroke. You will cause kidney failure. So keep that thing and bring it down gently in that. So the first hour, you want to reduce the mean arterial pressure by 25%. Over 2 to 6 hours, you want to get to about 160, 100. Over the next 24 hours, you want to bring it down a little bit more. So it's over 48 hours that you will now start getting close to goal, 150, 90, 160, 90. Even at that, once I get to 160, 90, you can allow the patient on that. Allow them to monitor them for a while and wait for some days before you now try and bring it down again. So stepwise is the way to go. So for drugs, if you have hypertensive encephalopathy, please avoid hydralazine. If they have a stroke, avoid hydralazine. I know hydralazine is still, people still have it, please avoid it. Whenever somebody has encephalopathy, rule out stroke first. Now, in stroke, sometimes we give antihypertensive therapy, but it is only when you have treated cerebral edema and blood pressure remains high and the blood pressure remains above 220 over 120. That is when you give. Even then, you still want to keep the blood pressure above 160, 90, above 160, 100. Just the same way we talked about that. In eclampsia, avoid nitroprusside. You may use labetalol or nicardipine and then give your magnesium sulfate and then consider hydralazine. Hydralazine is low down. The reason that hydralazine increases intracranial pressure, so it will worsen somebody with a stroke, and people with eclampsia, it will worsen the seizure. So, except you have no other choice, but as of now, in Nigeria, you should have other choices. In MI2, avoid hydralazine. In MI, we want to use nitroglycerin instead of labetalol, better. But if you don't have nitroglycerin IV, you can go to labetalol. But nitroglycerin is the drug of choice. Opens up the coronary blood vessels, because if you bring down the blood pressure at once, it may also reduce the blood supply to the myocardium that's already not getting enough blood flow. So nitroglycerin, while it brings down blood pressure generally, it opens the coronary blood flow. So it increases blood flow to the heart. So that is why nitroglycerin is drug choice number one. And then maybe nitroprusside as well. For people with pulmonary edema, if you give labetalol, they will die in front of you. They come in, they are breathless, they cannot breathe, their blood pressure is 200 over 150. If you give labetalol, they will die. Do not give labetalol in acute pulmonary edema. Do not. Somebody is hearing this. I'm saving somebody's life and somebody's license now. Listen, write it down. Do not give IV labetalol in acute pulmonary edema with high blood pressure. You want to give nitroglycerin best, nitroprusside next best. Okay, if you have nothing else, you might go to hydralazine before you come to labetalol. Labetalol should go nowhere near acute pulmonary edema. The patient will die in front of you. Please, please, please. How many times did I say please? Please, one more time. And in dissection, avoid hydralazine and catecholamine excess, either from fake chromocytoma or people that take wee or take drugs, cocaine. You know, you should be careful about the drug you are using. The most important is that you don't want to use beta blockade, unopposed glucan blockade, because it will cause trouble. And in pregnancy, the most important thing to note in pregnancy is the drugs. Anytime blood pressure is above 140 over 90 or 125 over 85, it should be treated. You might start your lifestyle therapy, but you should have very close follow-up. And once it is greater than 160 over 110 in a pregnant woman, that is severe. You need to admit and take care of it in a monitored setting. But you don't want to bring pressure too fast or too much because it will affect the fetus. So I'm rushing to meet up with time so that we can have. And in pregnancy, the main drugs are Aldomet, labetalol, and ifedipine. So again, just like we said, start with one drug, start low. You might add a second drug before you now start increasing the drug. So very simple what we have to do. I can see we have over 200 people. This still logged on. We are talking to you from Cardiocare. We're talking about hypertension management in Nigeria. So again, diagnosis, recertify, educate, treat to target, and clinic follow-up. Remember that it's for life. I will end with resistant hypertension, but I will not talk much about it because we already explained it. I think we'll just move. When do you refer? Anytime there's an urgent treatment need, acute coronary syndrome, stroke, severe hypertension, hypertension emergency, please refer. They need to be managed in an ICU setting. The ideal way is not even just manage, we put an interarterial line so that we are seeing the arterial blood pressure beat by beat as we are giving the drugs. So it's not when, before you finish pressing the sphic to the measure, the blood pressure could have crashed into better trouble. So you need all of these things. If there's possible secondary hypertension, people that their blood pressure is not controlled, despite being on 3 or more drugs, resistant hypertension, Okay, what are the other reasons why they should refer patients?
Difficult patients,
Yeah.
an unclear clinical situation,
Yeah.
and then other situations, for example, unusual blood pressure variability, possible white coat effect, hypertension in pregnancy, and then end organ damage.
So anybody that's having heart failure, having MI, heart attack, please get them to a specialist. Cardiocare is one of the hospitals that specializes in this. So everything about us is around treating heart attacks, heart failure, hypertension, severe hypertension, uncontrolled, even the difficult patient, people that have drugs intolerance to multiple drugs. So those are some things. Of course, I didn't tell you all our tricks. So hypertension is very important, right? It is if you take away hypertension, I think healthcare costs will crash significantly. So this is Cardiocare. I think I'll start looking for questions and comments. But before we do that, Cardiocare is a pioneer indigenous standalone institution in Abuja. It's under the auspices of greater than 40 years of experience, multiple awards of excellence in service. And last week, we completed about 10 or 11 cardiac studies for children, charity. We also do a lot of charity work. We do lots of stents, pacemakers for heart attacks. So if you have a heart attack, get them to the hospital as quick as possible. And we're also passionate about Nigerian healthcare, which is why we are bringing you this webinar free of charge. And you can watch it again, get to our website, you see the links there, or our YouTube page. Share it to your people, replay it for your staff, let them hear it over and over again. It will really transform the lives of your patients. So everyone does not need to go abroad. This is one of our corridors in Cardiocare. We are here to be able to take care of advanced care. And thank you very much for having us. We will now take some questions that are in the chat box. If you look on the screen, you see our phone numbers and the QR code that you can use if you need to refer a guest to us. Okay. So I think let me try and see if we have questions. If we have questions, Lupe has left the slide. Let's see whether we can bring her back to this. Okay. Now I've left the slide. Okay, so we'll continue to manage. All right, so let's try and go over questions. There are quite a number of questions. Is there anything like hypotension in a stable patient? So yes, hypertension is possible. Anytime somebody has hypotension and is symptomatic, we call that that person is unstable. So hypertension is almost always an unstable, it's almost always an unstable assessment or whatever. Patient is always unstable in that regard. So sorry, just a minute. I'm trying to see. Okay, so every time that happens, it's always an unstable situation. So now, some people have running normally low blood pressure. If they are asymptomatic, leave them alone. Okay, if they're asymptomatic, leave them alone. But if they have issues, go ahead. How do you diagnose and manage hypertension in children? So tune into our webinars by Living Children's Hospital, and Dr. Peter will handle that as one of the topics. But suffice to say, it's the same thing essentially. Measure the blood pressure in the children. We have coughs in our Living Children's Hospital, and the pediatric cardiologist is also there, can help with that. When can somebody say burnt out hypertension or decapitated hypertension? Okay, those are terms that were formed by certain people in Nigeria. They're not universal terms, but the idea behind them was that somebody could have had high blood pressure for a very long time, and now they are coming to the hospital, and it is looking like the heart is dilated, everything is there, and blood pressure is looking normal. So what do we do? Do we say they don't have hypertension again? So in that case, people now created this term called burnt hypertension. It was very high before, but it's actually damaging everywhere now, and so it's no longer high. Okay, so that's what we mean by burnt out hypertension. What is the lower limit of target blood pressure in elderly patients? Okay, so for elderly patients, we typically allow blood pressure up to 150/90. We're not very strict, go to 150/90, but sometimes maybe go a little bit lower. There is no lower limit per se, but at any stage that anybody feels symptoms of hypertension is low. There was once I had a patient, once the blood pressure touches 140/80, they start feeling some dizziness, they start feeling some lightheadedness. That blood pressure is too low. So for that person, you keep over. Suffice to say, you want it between 130 to 150 over 80 to 90 for most adults. All right. Can someone with normal blood pressure have stroke? Yes, very, very, very true. Someone that talk about digital fix. Most digital fix are accurate. Most are accurate, but they just give a pointer, and they are not recommended for clinical settings, except you have a professional fix. So there are professional digital fix that are needed. So in that scenario, so that is essentially what we try and do. Try and get a professional speak for your clinic. Otherwise, it is very difficult to say that they are working in that regard. Okay. Um, Let me see if there are any other questions. Things like moduretics should never be used as a full tablet. They should typically be used at most a half tablet. Okay, so don't use moduretics as a full tablet. Please use it as a half tablet, because moduretics has very high dose of moduretics has very high dose of thiazides, and could be implicated in causing different problems, including diabetes. Somebody say, what's the blood thinner? Thank you, Dr. Alabi. Senator Dr. Alabi, thank you for joining us. I'm very happy for you to see you. So what's the place of blood thinner in hypertension? There apparently is not any place for blood thinner hypertension. Blood thinner is not used in hypertension, except there are other reasons for the blood thinner. It is not used in hypertension at all, at all. So it is not used in hypertension at all, at all. So there's no place for blood thinner hypertension. If somebody, however, has clots in their heart or other things that may be happening, then they might have blood thinner for other reasons, but not for hypertension. Again, we're coming from Cardiocare. You may rewatch this presentation on our webinars, on YouTube and on our page, and you could join our WhatsApp group so that you can get access to a lot of get access. Stop that. You might get access to a lot of you might get access to a lot of materials that it could be very important for you. Okay, so what is occult hypertension? Well, that's like max hypertension. So I presume that what you mean by occult hypertension. Patient is having normal blood pressure in the clinic or having high blood pressure at home. Okay, how do you manage libido in a patient with hypertension, regular hypertensives? So patients, almost all antihypertensives have the tendency to cause low libido or erectile dysfunction. So what do we do in that situation? Essentially is to find the drug that would work well for them. So you need to change their drugs. Aldomet is the worst. Diuretics are next worst. So ARBs are the least. So you need to walk around to find the one that is the best.
Asked about preferred arm in measuring blood pressure.
Oh, preferred arm in measuring blood pressure. Okay, fine. Essentially, we don't say about preferred arm. We typically do blood pressure in two arms and then choose the one that has the higher blood pressure. So if my blood pressure is always higher on my right hand, that will be the blood pressure that I will be using. Let me just take a quick note. Please, drugs like atenolol are not very good for blood pressure. So you should avoid drugs like that. They are not very helpful in blood pressure management. The reason is that atenolol may reduce the peripheral blood pressure, but they reduce very little central blood pressure. So the blood pressure in the aorta and the center may still be high while the blood pressure is looking fine to you. So that's what, in case that question of occult blood pressure is there. I think I've answered most of the questions. Yes, somebody will post the WhatsApp link now in the chat box so that you can do. Somebody's asking personal questions. Somebody uses medications like Sinopril, amlodipine. All these were necessary after I suggest. Okay, so generally, I cannot answer that. You need to see a doctor. Once the patient comes in, if the BP is 73/40, patient should go to the hospital immediately. You could be having a heart attack, you could be having an MI, you could be having so many things. So if the BP is like that, please and please go and see a doctor. There's it's not here. I'm not the one that said anything here. Please, that is an emergency. That is an acute emergency. Please, blood pressure is 73/over 40. No, you may be having an MI, it could be a heart attack, it could have cardiogenic shock. So please get to the hospital as soon as possible. Okay. Dr. Abonyi, thank you for joining us. You said, what happens to a 55-year-old lady with blood pressure 150/100 without any symptoms? She's not taking the drugs but praying over over it. Well, what I advise patients is that pray over your drugs and take your drugs. Prayer can also work through drugs. So 150/100 automatically is already getting to stage 2. Is high blood pressure. You need to do her full risk profile. The answer to this question is she needs education. And if you have a difficult patient, that's one of the indications for referral. Refer her so that we will do a full risk assessment and let her see the importance of taking drugs. We have seen patients that stop their drug on Thursday and come to stroke on Sunday. So you don't want that kind of thing for anybody. I think I've gone over. So talk about people with blood pressure without any sign of organ damage. That is low risk, 140/80. So those ones you might start lifestyle therapy. Remember, we showed a slide that said, okay, when do you start? For some of these ones that are in that regard, you may start lifestyle therapy for them. Okay. Okay, and let me see if there's any other question. If there's any other burning question, please add it to the chat. Please add it to the chat. If there's any burning question, please add it to the chat box so that we can go through it. So I just want to show you some of the things that we do right here in Cardiocare Hospital. So this is Cardiocare. That's the Minister of Health at the time. That was commissioned in the hospital, but the hospital is originally founded in 1982 under the Living Hospital Group. And these are patients with abnormal ECGs, heart failure, and you can see when somebody is having an abnormal rhythm, how they get a shock. And what we do is to put in a device. That device typically is like an ICD or a pacemaker. Very simple procedure, takes us about 45 minutes to do. And that device is a life-saving therapy. We put a lead through the area of the heart, and then we are able to prevent problems thereafter. Okay, so let me also show you this. This is a cardiac resynchronization therapy device. As you can see that we've put multiple leads into the heart. This helps people with heart failure to do very well. They're able to breathe better, live longer. A device is put in, the device is MRI compatible. It's a little bit expensive because it is the crown jewel of devices in interventional cardiology. But it makes a whole lot of difference. One is put in the coronary sinus around the left ventricle, another into the right ventricle, another into the right atrium. And it helps to resynchronize the heart and give a very fantastic outcome for patients with heart failure. So it's something that you should consider. Sometimes patients come with chest pain, and you can see from this ECG ST elevation. We have a webinar on chest pain. So go and listen to it on our page, and it will you really appreciate. And we go through this. If you're on the WhatsApp group, we'll share this with you. And then we can see that. So in that kind of case, we come to the cath lab, patient comes with the chest pain, excruciating chest pain sometimes. They come to the hospital. This is how Cardiocare looks here in Abuja. We are right next to Minister Wike's office, His Excellency. So in that case, we take a small needle, we do everything through a needle, no knife at all. Patients are awake, and then through that needle, we pass a tube into the heart to find where the blockage is. If you look at this one, you can see the blockage right here for this patient that had it. This is a 38 or 40-year-old man that had a heart attack. And we now pass a bloom, a balloon, and then we open up the blood supply, the place, and then we put in a stent, a small metallic scaffold that allows blood flow to go. This, we do it over 45 minutes, 1 hour. So this is what it was before intervention. And then if you wait, you will see after we've done all our work, you can see there's full blood supply to restore that area of the heart. That is very, very important for the heart. So this and many more is done here in Cardiocare. Numbers on the screen. You can refer your guests, your patients. Yes, the WhatsApp link is to join the WhatsApp group. The WhatsApp link is in the chat box. So look in the chat box. There's a WhatsApp link for you to join our WhatsApp so you can know about it. So it has been pasted. If you click on the link is in the group. Somebody said the link is not responsive. Please try again. Carry it to your browser. If it's not responsive, put it on your browser and click it there. It will open for you. Okay. What's the place of monotherapy in uncontrolled hypertension? Somebody asked a question. Yes, if blood pressure is less than 150/100, 160/100, you can do monotherapy. But we typically like to do dual therapy so that we use smaller doses of two drugs rather than use a high dose of one drug. Okay. Does aspirin should aspirin be used in antihypertensive if a CT scan showed ischemic changes? Yes, so we typically, I've told you how we use aspirin, but if patient having a stroke with ischemic stroke, we can add aspirin to their therapy. If patient qualifies, that is their ASCVD score is more than 20%. Their 10-year risk more than 20%, the aspirin should be added. If they're more than 50 and their blood pressure is well controlled, you can add aspirin. Okay, so thank you very, very much. The Cardiocare, somebody's asking for the Cardiocare WhatsApp number. The Cardiocare WhatsApp number is also, huh? Yeah, the Cardiocare WhatsApp number is also in the chat box, and there's a link to join our chat. In the chat group, you can ask questions, you can do, but please don't bring any patient specifics. For doctors and healthcare providers, and then you can know about our next meetings and all. Thank you very much for joining us. We had over 200 participants, and we are very grateful to you. We believe that Nigeria can be better when all of us put our hands together. Dr. Mpupe, any final words?
Much. I think the video will be on YouTube. Any more questions, you can type it in there.
Yeah. Thank you very much. God bless you. Have a lovely weekend.